Hi, this is Dr. Francis Price, and I'm going to share with you some of our new techniques for DMEK. This is the trifold technique, which we've been hopeful would decrease endothelial cell loss with the procedures, but it actually helps quite a bit, I think, with the insertion. And if you look at the right-hand side towards the bottom, we also have the intraoperative OCT on, which is fairly interesting. And you can see that we have probably a little bit extra fluid here with the trifold when we're trying to fold this over, so the donor actually tends to curl back up a little bit. So this is the first case we've actually been able to use the OCT on for the donor prep. Now this is an interesting donor in that it's 36 years old. Now the importance of the trifold is that when we do this, the Decimase membrane is on the outside and the endothelium's on the inside. You can see there the surface tension curls it up. We've loaded it into the cartridge. And of course, like most things in cornea, a lot of what I'm going to talk to you about is off-label. So using an intraocular lens cartridge to inject the donor is of course off-label. Using the trypan blue to stain the donor is off-label. Now, what we're going to do with the forceps is pull this into the tip of the cartridge, and we let it unfold a little bit so that still we have the Decimase membrane out against the cartridge. So we're going to put that aside, and now we're going to work on the patient's eye. And actually we do our donor preps before we even bring the patient in the room, but we leave them loaded in the cartridge as you saw there. Now we're going to make 2 stab incisions, and I'm going to inject 1% non-preserved xylocaine into the anterior chamber. And in this particular case, it's being combined with cataract surgery. We're now going to use Viscoelastic to fill the anterior chamber. And we're going to use a keratome incision that's clear cornea to start out doing the cataract procedure. At this point we have the intraocular lens in place, but we still have the anterior chamber filled with viscoelastic. So this is a reverse Price-Sinski hook that we're going to go around and score Decimase underneath the area that we did a trephination mark, which is the same trephine that we used to punch the donor with. Now, what's always amazing with Fuchs dystrophy patients is to look at the change in the red reflex in our view of the intraocular lens as we pull Decimase membrane out of the way. In many of the Fuchs patients, Decimase membrane is actually somewhat opaque. It's just that it's real thin. Plus we have the guttae. And you're going to notice that the view becomes much brighter and clearer, even though we haven't irrigated on the eye. It's even easier to see when we irrigate. And as Decimase becomes folded over on itself, you can see that it's even less clear and somewhat opaque. So we're going to take Decimase out, and now we're going to remove the viscoelastic. I always like to remove it first from behind the intraocular lens and in the posterior chamber. Now, one of the things that we think is real important is to remove the viscoelastic from the back surface of the cornea. And you have your marks from the trephination, and that whole area in there we like to go over and vacuum gently with the INA tip. And it's nice to do that, and easier obviously with a silicone tip like this. We've shown before with DSEK that if you have retained viscoelastic, that you'll get interface haze and opacities and actually some inflammation in the eye. So it's very important to make sure you remove all the viscoelastic from the back of the cornea. Now we're going to constrict the pupil with myostat, and I know there's